Hello, everyone, and welcome to one more episode of MetaCast, the podcast of the Meta-Analysis Academy. Today, I am honored to welcome Dr. Enrico Ferro, who is an Electrophysiology Fellow at Beth Israel Deaconess Medical Center at Harvard Medical School, has extensive research experience on a global scale, is a medical officer at the Food and Drug Administration, the FDA, and has a remarkable training journey coming from Italy for college in the United States, having undergone through training through Yale, Harvard Medical School, and with so much research experience to share with us insights here in MetaCast about building such a successful career and his passion for research on a global scale. Enrico, I'm so honored to have you here today. Thank you so much for joining us.
Hi, Anderson. Hi, everyone. It's an honor to be here, and thank you for having me on this great MetaCast initiative. I've seen some of the episodes, and it's been really inspiring to see the people that have sat here before, and I hope we can share some interesting stories for the audience today.
I'm sure we will. If you're listening for the first time, MetaCast is the podcast of the Meta-Analysis Academy where we share successful career stories. And I can think of no better successful career story than Enrico Ferro here. Before we get started, just a reminder that this podcast and what we discuss is not affiliated with the institutions where Enrico and I work. The opinions are exclusively ours. Enrico, let's talk about what your current day-to-day life looks like, your current job as an electrophysiology fellow, and then we're going to go through your remarkable journey so far. But I just give folks an insight on like what is it that you do on a day-to-day life?
Absolutely. Great place to start. So as an electrophysiology fellow, we deal with arrhythmias, so abnormal rhythms of the heart, whether it's too slow or too fast. And we have great tools to treat both. So to give a big picture overview, when it comes to slow rhythms, we can place pacemakers, or sometimes we need to place defibrillators to treat fast rhythms, like ventricular tachycardia. And then we do a lot of ablation procedures. So we travel with catheters, minimally invasive, so we go through the veins of the body, we enter the heart. It's actually, from a technological perspective, quite incredible. You can imagine, I'm sure you've seen some of these procedures yourself, but for people that are less familiar, the patient is lying on a table in the operating room, and underneath there is a GPS system with a magnet, and the catheters are also magnetic. So we create real-time a 3D structure of the heart of that patient, and we're precise to about 1 millimeter. And so we're able to then study the conduction properties of the heart to 1 millisecond of precision, identify the areas of interest, and then we deliver energy and we ablate, so burn away that tissue. And it's really revolutionary what we're able to do, and it makes an immediate difference in the life of patients. So it's really incredible, exciting in terms of a learning curve, the potential for innovation, but also very satisfying in the impact you can have on patients.
Amazing. And not only in quality of life, but survival too. I feel that one of the most remarkable things that you can do as an electrophysiologist is literally cure some arrhythmias. Like you can do an ablation, cure things like AVNRT, for example, like some types of tachycardias.
Absolutely.
Really amazing.
Sometimes you see the arrhythmia within 1 second, you step on ablation and the arrhythmia is terminated. So it can be very, very satisfying.
There goes that accessory pathway. Very good.
Exactly.
Excellent. So our audience, of course, is not just cardiology here, so we're going to go take it on a broader scale and focus on an incredible journey in medical education, and then we're going to talk about research. To become an electrophysiology fellow at Harvard, you did all the training up until high school, then undergraduate, then medical school, internal medicine residency, cardiology fellowship, and now an electrophysiology fellowship. Can you just give us an overview of where you did each of those steps of your training?
Yes, absolutely. So as you were mentioning, I was born and raised in Italy, and I was fortunate towards the end of high school to be selected to be an exchange student. And I traveled to upstate New York through Rotary International, which is an international community service organization that, among its stated objectives, has to achieve peace in the world and international collaboration. So one of the applications of these principles is that they allow students to travel and study in other countries. So I traveled to the US. And that's where I got really interested in its educational system, especially, I would say, in the meritocracy of a system and the open-mindedness of a system that tries to really bring out the talents within each student, whether that could be medicine or business or arts, and empower them with resources to bring their vision to life. So after terminating the year, I applied to college in the United States, specifically because I was interested in the meritocracy. And the first step of this journey, as you were alluding to, was at Yale University, so Yale College. That's where I completed my first step as a pre-medical student, so the pre-med journey, and a baccalaureate in molecular, cellular, and developmental biology. And we'll cover some of these topics later, but that's also where I started to develop an interest in global health. And so we conducted some research in HIV and treatment outcomes in Peru and Malaysia with Dr. Ricaltis. That was a wonderful mentor of mine.
Just to be clear to the audience, because a lot of countries there isn't undergraduate, at least in Brazil there isn't, for example. Just to be clear, this is all before medical school, during undergraduate, during college.
Absolutely.
Yeah.
So that's the first 4 years of the journey. So you don't have to be a biology major, but you have to be a pre-medical student.
Being a pre-medical student means essentially have to take some classes that are needed to join medical school later.
Exactly, to be practical, biochemistry, biology, cellular biology, and so on. So that was, to answer your question originally, that was the first part of the journey. And then I applied and was selected to Harvard Medical School. That's another 4 years of training. That's a core medical school training, if you will. And that's where I continue to develop my interest in cardiology specifically, that I'm sure we'll have a chance to cover, and start to conduct research now in clinical outcomes. So looking at large claims databases in the United States, whether it's Medicare or other insurance companies, and understanding how new cardiovascular technologies, devices, or policies are implemented in the real world and the outcomes. So that's 4 more years of training. After that, it's time for residency. So residency in internal medicine at the Brigham and Women's Hospital, all the way across the street from Harvard Medical School, where I believe you're currently based.
That's right.
And that's 3 more years of training. I'm sure we'll cover that as well, but the Brigham is really a wonderful institution, almost a pre-cardiology fellowship within residency. You get to learn from the legends of cardiology that are working in this institution. And then 3 more years of general cardiology. Again, across the street, I have a Beth Deaconess Medical Center, which is also part of Harvard Medical School and the teaching hospitals. Also another wonderful honor to be there, specifically given my interest in electrophysiology, given that the field was its early development. Beth Israel was part of this through Dr. Mark Josephson. And that's where I'm currently based.
That's an incredible journey. Congratulations. First of all,
you.
That's incredible. I want to go back to the beginning of that journey just for one quick question, which is the decision to come to the United States. You mentioned meritocracy being one of the key motivators there in that decision. It is, I'm not sure what it's like in Italy, but at least in Brazil, there is no such thing as college or undergraduate. So people go from high school into 6 years of medical school. And I get this question a lot by people who are junior in their training, or the parents of teenagers who are about to jump into this journey of doing medical school in Brazil or in other countries around the world, and then coming to the United States for residency, which is kind of what I did, versus trying to come here to do college, undergraduate, and then apply to medical school. And I always tell people to have caution with the second approach, which is the one you did, because you end up applying for medical school later on, after you've done. And it can be challenging as a non-U.S. citizen or as someone who otherwise came from another country. Can you just make a couple comments on what it was like? Obviously, you did college or undergraduate in a phenomenal institution. You were an amazing student. I think you were valedictorian of your graduation.
So
You're gonna tell us what that is in just a second. So, just what was it like to go to apply to medical school? Again, with the caveat that you did so well, and I'm sure you were quite confident. But was that ever a concern? I guess that's the question. That you're essentially postponing your application into medical school by 4 years by doing undergraduate under this U.S. system, let's say.
I mean, that's a great point, and it's certainly a very careful consideration to be made, not just because of the difference in the educational system, but it really changes your life. You're uprooting yourself from home, and you are going to another country, another culture, another system, and you're leaving behind family, friends, all your system and your support network. So it's a big decision not to be taken lightly. But provided that you feel comfortable with all of that, and I'm just looking at the the facts, what is it like to train and defer versus go straight? I think it really depends on what you're hoping to do. And in my case specifically, my interest was to become the best doctor I could in taking care of patients, but I also had a strong interest in becoming part of a broader ecosystem of medical innovation. And I felt that the United States in this current period is really the leader in having access to the resources, the network of minds that are propelling innovation. And so that to me was a distinguishing factor of I want to get the broader exposure starting through college, starting to see all the other complementary aspects to pure clinical training, and then continue through clinical training. That was my thinking, at least.
It's beautiful. I mean, it's because that actually happened in the sense that you acquired really great skills during those 4 years and had unique experiences in networking that ultimately led you down this brilliant career that you've had so far. Would you agree?
Yes, I would agree, and I'm very grateful for the opportunities I've been given, both at Yale and Harvard. I'll share some numbers just to put things into context because, as you start thinking about this journey, you have to stay humble and pretty practical and focused. If you think about Yale, on average, they accept about 1,500 students from all over the world out of a pool of 30,000 students.
Wow.
So you're looking, at about 5%. You look at HMS, Harvard, you're looking at 1,500 students out of 6,000 applicants. So you're looking at 2.5%. So every step the funnel gets narrower and narrower. I'm saying that mostly to say that you have to stay focused and realistic. You have to plan because usually you get one shot at this. And once you're in, you need to keep that attitude to really understand that it's an honor you have been given, a big opportunity, and you owe it to yourself and to the network of people that have supported you, your family, your friends, your mentors, to really make the most of it. And I would say what sets these institutions unique, it's the fact that certainly you have access to wonderful educational philosophy, and you get to learn from Nobel Prize winners to the leaders in education, medical education or general education. But B, these institutions really challenge you to constantly think in a very critical way about what's known, about quote unquote dogmas, and challenge the status quo and always be challenging the assumptions and develop your own skill set. I think that's what makes them unique. But they also really give you the resources to do this. And by resources, I mean the financial support, not so much financial aid, I mean so much as research grants, travel grants, coaches, tutors, resources to grow. These are not granted. Just because you are part of an institution doesn't mean you're getting access to them. You need to continue applying and applying and applying. So they really force you to plan very carefully each step. Certainly, if you have a plan and if you have a vision and you can convince others of your vision, then the sky's the limit. The resources they give you really make a difference. And lastly, I would say what's unique is a network of peers. Everybody there is on a mission, has a purpose, and just by talking to your peers, literally your classmates, what are they passionate about? What gets them up in the morning? What are they thinking about? It's a virtuous cycle where then they stimulate you, you stimulate them, and multidisciplinary collaboration begins. And of course, a network of alumni. So people that are willing to help, mostly because they used to be like you. They used to be a student. They got where they are by being mentored, and they're willing to pay it forward and give back. So I think that's what's unique about these systems that really allows you to explore all your interests.
Yeah, it's outstanding. And Enrico, can you tell us a little bit more about the research that you did at that time in Yale, like the global experiences? What was that like, and how did it help you eventually later on in your career?
Yes, absolutely. So the work we did at Yale, again, through my mentor, Dr. Rick Altis, it was focused on HIV and treatment outcomes. Certainly, I'm not an HIV physician now, I'm a cardiologist, but that was the building blocks, the foundations of outcomes research. So we did work in 2 countries, in Peru and in Malaysia, where there are very specific dynamics in HIV transmission patterns. In Peru, it has to do with alcohol use disorders, for example, and changes in social behavior which may promote transmission of sexually transmitted diseases. And in Malaysia, it was similarly, but it was related to intravenous drug use. And what's unique about these experiences is that they start to help you understand all the elements that, in addition to pure pathophysiology, are then responsible for disease transmission on a epidemiological and system level scale. I'll give you an example. So when we worked in Malaysia, we collaborated with the Ministry of Health to launch a nationwide survey to reach all the HIV physicians who were prescribing antiretroviral therapy, about 200, 250 of them. And our goal was to understand why is there such a concentrated HIV burden among people who use drugs, intravenous drugs. Certainly one may say, well, they may share needles and they may promote transmission. But we also found that they were less likely to receive antiretroviral therapy. And as you dig deeper through surveys, focus groups, you understand that because drug use is illegal and can result in spending time in prison, and access to antiretroviral in prison is limited, then physicians were worried about initiating antiretroviral therapy with the fear of promoting resistance once the access to antiretrovirals was limited. And so you really start to understand how we have a great treatment, it works, the way to prescribe it is understood, but there is a whole other layer of further complexity and nuances that then we could report back to the Ministry of Health to target interventions back. So that was some of the work we were doing.
And you can only get that information with like boots on the ground and like being
Exactly.
at the level where things are happening.
Exactly, because also these dynamics may be unique to that population, that community. And certainly, again, it's a learning experience if you want to take that back to a broader level, but you need to keep in mind the country level perspective and why there may be hotspots in specific areas.
Amazing. Now, in this podcast here, I've had the opportunity to talk to some incredible people who've shared different types of research. We talk a lot about meta-analysis. I have a program called the Meta-Analysis Academy. By the way, if you're not a part of it yet, I recommend that you join the wait list for the Meta-Analysis Academy. We've had Andre Zimmerman come here and talk about clinical trials, and you have extensive experience with observational data. You just mentioned about global health, but also talk us through some of the great research you've done at HMS, as a medical student, and then later on as an internal medicine resident and cardiology fellow, with observational studies, using real world data to make decisions. We all hear about the limitations, but we can't do randomized controlled trials for everything. So I'd love to get your expertise on that topic.
Absolutely. That's another great topic to cover. So since 2015 or so, when I was at HMS, I've been fortunate to meet and start working with Dr. Bobby Ye and Dr. Eric Sasemsky, who are currently based at the Smith Center for Outcomes Research at Beth Israel Deaconess Medical Center. And their expertise is really to develop what we call quasi-observational methods. That's a mouthful, but what it means is trying to recreate experimental conditions using observational data. I did follow with great interest when Andre Zimmerman was here to talk about trials, and certainly they remain the gold standard. But we know there are limitations, and we don't have to go through a full lecture about that, but generalizability, whether you can run a trial, whether you can't, and even within trials, whether you're able to really abide by the inclusion-exclusion criteria and so on. Most importantly, it's a very selected population that enrolls in a trial, and so you wonder, well, what happens when this data is out and people start doing those procedures, so they start prescribing those medications in the real world? So that's where we have developed this interest. Certainly, the real world is very powerful. There is a lot of data. Most time it is observational. So you have not, what does that mean? You have not imposed a treatment. You're just observing what's happening. And it's retrospective. It already happened. So there's a lot of what we call bias. So somebody may get a treatment because of a variety of reasons that are not controlled like in a trial. So we use these methods, which have actually been invented and originally developed in econometrics, and we apply them to medicine. Let me give you an example here, again, to be concrete. Let's say that you love cardiac MRIs, I assume,
Definitely.
and you believe that it should be done every time for a patient that comes with suspicion for myocarditis. And let's say that your colleague across the street actually believes they are absolutely not ready for prime time as a technology and they never use it. Well, effectively, if every patient that comes to you is effectively being randomized to getting an MRI, and every patient that goes to your colleague is being randomized to not getting an MRI. So you can use your treatment preferences as a retrospective randomization. Again, this gets complex, but these are ways in which we can recreate quasi-experimental conditions.
I know it gets complex, and we could talk about this for a long time, but since our audience, at least part of our audience, is quite savvy in terms of like research and bias. In the example you just gave, how do you deal with confounders? Because the reasons why patients came to see me and not the guy across the street who doesn't like cardiac MRI may also influence the outcome,
Right.
not just because he had the MRI, but maybe, the clinical cardiologists here are better and doing better things, and not just because they got an MRI. So how do you deal with the confounders in that example, which may influence the outcome in the context that decision was not effectively randomized?
Right. Certainly, these methods are not perfect. But what you can start doing, and there is a beautiful article by Dr. Yale, I believe in Circulation recently, that talks about how to think about observational research, but you do have to combine the statistical know-how with the clinical intuition or expertise. So certainly, you already started to mention items or variables that you think may be different if somebody comes to you versus across the street. And so you want to test for those specific variables. So if you stratify by MRI users versus not users, and then you pick the variables, and you can include as many as you wish, and you test. Are these patients looking similar in the classic usual suspects versus additional variables? So you have to prove your hypothesis. It's a step-by-step process, which ultimately is not perfect, but I would argue that sometimes there are other measure factors, even in randomization, that may not be in table 1, or patients may be different. So it's just arguing that trials are not perfect, observational data is not perfect, and ultimately you have to combine statistical knowledge with clinical expertise to draw your conclusions.
I think that's just a great way of summing it up, because ultimately I think people need to go beyond this dichotomy of like RCT is great, observational is not reliable, or, obviously they're more subject to bias, but I think there's a dichotomy that I think overemphasizes or overestimates maybe the power of RCTs, and maybe underestimates, the value of observational studies.
Right, absolutely. And it does have some real impact. If I can give you a couple of examples, so recently we collaborated with the Food and Drug Administration on a very common problem and topic, which is inferior vena cava filters. And the study, we recently published it in JAMA, is called the SAFE IVC study, because there is an ongoing debate about the safety of IVC filters. And I'm using words very purposely here. I'm not talking about efficacy. I'm talking about safety, which is very important. So are these devices safe? If you place them, what are the risk of complications? If you leave them in the vena cava for months or years, what happens? Do they form clots? Do they embolize? If you try to remove them after several months or years, what's the risk of having procedural complications? So that's a safety question. And if you look at trials, they are there, but the sample size is very small. And if an event like a filter embolization is very rare, then trials will conclude that there is no difference. But now, if you leverage Medicare for 6 or 7 years, you understand A, what's actually happening, and B, we had a sample of 270,000 filters, where safety outcomes, you may argue, they're less subject to bias. It's just, did this complication occur or not? The question becomes, how do you compare patients? And that gets trickier. But if you want to understand what is the absolute rate of complication, should I be worried as a physician? Should I be worried as a patient? that really gets you an understanding of what's happening in contemporary clinical practice. So it's not just comparing, but also describing what's happening in the real world.
That's such a great example. I was going to ask you, you mentioned Medicare database right now. I was going to ask you, what are the most common databases that you use? Are they built by the hospital systems, Medicare, National Inpatient Sample? Like, if you could just walk us through the 2 or 3 most common databases that you use, and then how do you gain access to them?
Right, absolutely. That's a great point. You have a lot of great ideas, but then you need access to data. So Medicare certainly is the most common. And that may also now start to include both fee-for-service and Medicare Advantage. So whenever private insurances are helping to provide the benefits. The National Inpatient Sample is another very important one, and some of them start departing from just being Medicare by having multiple insurance companies, which is very important because each provider of insurance captures a specific population. So to be more specific, Medicare is mostly going to be people older than 65 years of age. And if you wonder about things that may affect younger patients as well, then you may not be able to answer your question there. The other one that's very commonly used by us is the NCDR, the National Cardiovascular Data Registry, which is much more granular from a clinical perspective because Medicare, it's insurance claims. It doesn't have clinical data, but then you can start combining them. And to answer your question about access, they are accessible through applying. Oftentimes you need to provide, for example, for the NCDR, you need to provide a question and they need to evaluate the question as they've been asked already, is there an original question and so on. And unfortunately, there is a cost to access some of these databases like Medicare. Again, going to the point of why it is so important to highlight the value of this institution to provide resources through funding to support an idea, provided that you have a vision and a plan.
Fantastic. You mentioned the FDA a little while in one of your last answers. Walk us through how you got involved with the FDA and what is your role as a medical officer. What does that mean, and what do you do related to the FDA?
Absolutely. Maybe I'll take a little detour to get to that in terms of why did I have this idea, like what's interesting about it. And through the course of training, I started thinking about, well, what is the life cycle of a new idea? What is the life cycle of medical innovation? And I think we have all experienced some aspects of it, certainly as physicians or in general healthcare professionals, we have experienced the unmet need. We take care of patients every day. We see the good and the bad of medicine, and oftentimes we just face a barrier, something that cannot be done. And you may develop an idea. How do I fix this problem? That's just the start. I think most of us have experienced the next step, which is research. Well, I have an idea, I have an hypothesis, I want to test it, I'm going to get data, and I'm going to test my idea. And that's research, whether it's through clinical trials, observational research, meta-analysis, and so on. Well, what happens next? That idea remains an idea, even if it's published, but then how do you actually bring that to the patient, right? So next step is starting to interact with what I like to call enablers. So other entities that enable you to bring that to the patient. Important ones are funding entities, whether it's non-dilutive funding, so the NIH, foundations, which if they share your vision and it aligns with their agenda, they may support you to start creating your prototype, or dilutive funding, whether it's venture capital and so on. Next, you may start developing a product. The product you may start developing within your company, or you may rely on bigger companies that are then sharing their know-how, their distribution to make the product a reality as the results from your studies come back. Then, one is not creating like a new app or a new tennis racket that you can just put on the shelf and start selling, right? You are about to launch a new drug or device into human beings. So there needs to be an entity, a regulatory body, that needs to make sure that what you're doing is effective and safe. And that's where regulatory entities like the US FDA or the European Medicine Agency and so on come into place. And so as I started to understand this life cycle, I was very curious to understand, how do you make this decision? How do you evaluate something that's new And oftentimes by being new, it means there is not a lot of data. You can't just say, oh, this is how it's gone up until now, therefore we'll follow this trend. Something, it's by definition new. And so how do you evaluate safety and effectiveness? And that's where these entities come into place. So the work at FDA has been incredibly stimulating. You are part of a multidisciplinary team, which includes you as a physician and the medical officer, but it may include veterinarians, as oftentimes the first studies are conducted in animals. It may include biomedical engineers who are very savvy with the construction of a device and its functioning, the biocompatibility, and so on. He may include regulatory experts, lawyers, biostatisticians, and they all come together
Like a committee.
as a working group,
Okay.
to look at all the data that's available. And the data can come at different stages. It may be in-animal data used to support first-in-human data. First-in-human data needed to support a pivotal trial. So again, in the development of that device or that drug, each time there is a different level of contribution that you may be asked to give. But your job as a physician, as a person who has been in the front line, is to share your clinical understanding of that data and ultimately help to make that determination. Is this device or this drug effective and safe? We can go, of course, into more regulatory science, but in general, the idea is it truly brand new, and so it needs to be a pure pivotal trial? Or is there a precedent? Is there something similar enough that can be used as a benchmark? And so that then guides the decision-making process.
I'm sure devices and drugs try to go the second route, on trying to say that they're similar to something that has already been improved.
That can be a strategy, but also depending on the level of risk, that may not be allowed. If something is very high risk or a category free, so oftentimes it's required to go through a pivotal trial. It's usually randomized. So it depends also on risk.
This is so unique and interesting. From an operational or logistical perspective, this committee or this working group, as you mentioned, you make recommendations, like is there a report, and then there's someone or like who makes that final decision, let's say?
Well, the individual members make recommendations. And it's truly a team sport because as a physician, you may be an expert in pathophysiology, but you may know nothing about animal models. That's why you have a veterinarian and so on. So each one weighs in. And at the end, this group makes, you can call it a recommendation, but it's effectively a
Decision.
A decision.
Gotcha.
Whether something can enter the market or not.
That's incredible. How did you get into this, Enrico?
It was through this step-by-step exposure to the system, because as you conduct research, and I'm sure you may have this experience too, you may start interacting as a researcher with some ideas with the regulatory entity. And so those interactions made me curious to understand what's happening, how are these decisions being made. That fueled my curiosity to apply and then serve within the body.
You know, it's your story is so unique because you have this incredible pedigree, let's put it that way. Like you've trained at these best institutions. You've done great clinical training, HMS, Harvard Medical School, then Brigham and Women's, and then electrophysiology at Beth Israel. But you have such a diverse like research background and experiences internationally, population health, global health, and then outcomes research and the FDA. Where do you see your career going? Like with such a great training, and then also such unique experiences, and also a lot of different experiences. What comes next in your career?
You're too kind, but to answer your question, I just think that we as again physicians, healthcare providers are in such a unique position when it comes to healthcare. Healthcare is a very complex environment, and as I started to describe through these multidisciplinary teams, but in general, there are so many different stakeholders. But I think that what makes us unique is that we live and breathe the topic of the field. We take care of patients. We see the good and bad. We see the limitations, the wins, the losses. And so we have a unique understanding of what's happening in the field, what's needed, and what can be achieved right now. And so I think my hope is that through this clinical training and clinical practice, because training becomes outdated pretty quick if you don't practice it, right? You need both the repetitions, but also to stay up to speed with what's happening. But then you can have quite an important seat, a contribution at the table of innovation, and really share your unique perspective with these other stakeholders that have orthogonal abilities, but then really work together to bring something new. So that's what I hope to be able to achieve, is to continue practice, understand what's needed. But oftentimes, for those ideas to become a reality, you need to be able to both understand and speak the language of the other people that are making this innovation vision possible to work together.
Beautiful. Incredible. And you said that I said kind words, but it's not just me who thinks very highly of you. Tell us about this Italian Award of Honor. I wanted you to explain it to everybody because I was so fascinated by this.
Well, it was a big honor for me, as certainly I owe a lot to the United States as the country where I've done pretty much all of my adult and professional learning and training. But I am also very proudly connected to my home country of Italy, and I'm very proud of our heritage and culture and achievements in medicine and beyond. And this award came as a big surprise and honor, and it's given by the President of a Republic, which I guess would be the equivalent of a President of the United States. And it's given to individuals who are recognized for their merit towards the nation and what they have contributed to improve society at a broader level, not specifically the Italian society, but as an Italian citizen that has contributed. And so it's awarded in all fields. So within the field of medicine, it was recognized at different level of contributions through the clinical contributions in working in hospitals and taking care of patients, the research contributions, and the work within medical innovation as a portfolio that they consider to be worth of service to the nation.
Congratulations. That's such an incredible
Thank
award.
you.
At a junior phase still of your career. So very well done. Enrico, you mentioned at the very beginning that your transition to the United States, your first time in the U.S. was through Rotary and through the exchange program. Can you tell us a little bit more about that institution and if you've stayed involved and how it shaped your career, this global vision through Rotary?
Absolutely. I've been involved with Rotary International for a while. In fact, since high school. And that was, for me, the launching pad to initiate my career, also discover the United States and its educational system. But Rotary was actually an organization that was founded at the beginning of the 1900s in Chicago. So it is a US-based organization, but nowadays it's present pretty much, I would say, in every country in the world. And the principles are the same, which is to foster, as I was mentioning, international collaboration to bring peace and development. These groups, it's a nonprofit organization, a non-governmental organization, and the work that you can do through Rotary, I would say, in some aspects, does align with medicine as its community service and service. The motto of Rotary is service above self, and I think a lot of these ideals overlap with medicine. One of its biggest and loftiest goals is actually the elimination of polio. So there's a lot of collaboration between Rotary and the Bill and Melinda Gates Foundation to eradicate polio. But there are also very specific goals that the clubs try to collaborate with each other to promote. You asked me if I've been involved ever since, and definitely I have. During my time at Yale, actually, the Yale club of the Yale Rotary Club was very active, and it had a very strong collaboration with the Mumbai Rotary Club due to prior students. And to give an example of Rotary in action, during my time at Yale, we launched an international project. They received about a $40,000 grant from the Rotary Foundation to build a vocational training center in the outskirts of Mumbai. So the idea, of course, came from the local club of Mumbai. Again, the presence on the territory understands what's needed for the local community. The resources are there, and the collaboration was needed both for fundraising purposes, but also for sharing knowledge and tools. So the construction was done, of course, locally, but then since the construction, we were the first team to then travel in the site and start different courses within the vocational training center. We specifically being healthcare professionals, we launched a first course in first aid and healthcare hygiene and sanitation, which was actually one of the biggest problems in the area due to the fact that the concepts of hand hygiene, water sanitations were developing in this rural area due to recent urbanization of the area and recent introduction of water, um, uh, harvesting the monsoon rains. So it was development, but there was also a need to both educate the local community, share tools, share skills for local empowerment. And it was really wonderful to be able to participate in these sessions, train or help train the first generation of local healthcare workers who could then remain in the territory and help spread these principles of hygiene and sanitation so that the community could then start focusing on other activities without having to deal with continuous cycles of infections and waterborne illnesses. So that's an example of what Rotary does, and that is still stuck with me as something that I'm very passionate about. And again, I think overlaps well with medicine and its causes.
Definitely does. As we wrap up here, I want to take the opportunity that you've mentioned so many different topics in terms of community service just now, global health, research, and mentorship. You've talked about it a lot. And I may be wrong about this, but I think you're the first guest that we've had that actually went to Harvard Medical School. We talk a lot about HMS as in the institutions, Mass General and Brigham and Beth Israel, but the actual medical school. And this is a question I get a lot by international graduates who don't understand sometimes the competitiveness of what it takes to become a HMS student. But just you mentioned a little bit earlier on about the numbers, but what is it that actually people have to do to be competitive in the sense of, I could assume, being a complete applicant with all the different things that I just said, community service and research and obviously great scores. But can you just give a little bit more insights on what it takes to actually be accepted into Harvard Medical School, just as we wrap up?
That's a big question, but we'll see how we can break it down. I'll share that during my time at HMS, I have worked and served on the admissions committee.
Amazing. Even better. So that we're listening from the pro.
I've had the chance to witness that in action and participate in the decision-making process. And what I would say is one of the cardinal principles is, A, are you passionate about what you're doing? And what have you accomplished with the resources you have been given? And I don't mean to be idealistic and generic, but these principles then do, carry down to the nitty-gritty, meaning usually people that have a passion, they have a dream, they don't need a checklist. They're just following their passion, and that leads them to participate in all those activities that make sense to pursue that passion. In fact, I would say the checklist approach does the opposite. It may be very fragmented, versus a coherent passion will lead them to achieve all the things that give a sense that you have a goal.
Like your story, everything is connected.
I hope I can transmit that concept. I think it is, but certainly having the ability to explain what you're hoping to do, and you're not bound to that decision, but it shows that if you have a goal, you can set your mind to achieve that goal, and everything else follows in terms of activities. But importantly is the second piece, is what have you done with the resources you have been given? So there is a lot of awareness of where are you coming from? What resources did you have in your local community, in your college, in this case, or earlier on, high school and so on? And have you really make the most of these opportunities? Going back, I guess, to what I was saying earlier, with you owe it to yourself and to your network of supporters to make the most. So there is, if you will, a normalization for what you have exposure to. I mean, if you happen to have gone to, say, a college that doesn't have a medical school nearby, nobody would expect that you would travel to who knows where to do medical school level research. But within that environment, have you found your way to achieve your goals? So I think those are some of the guiding principles that can help you make decisions on what to do.
That's such an incredible insight. I've always thought of it as having like the complete application in the way that I just mentioned. Maybe it is a checkbox approach, but I always thought, oh, you need to have community service. You need to have great research. You need to have great letters of recommendations for people who will support you. But I think it all connects in what you said. It's having a story, having a passion, and then that insight about the doing the best with the resources that you were given is a great one. I hadn't heard that one before. Great to listen to that from you. This is the final one, I promise. I've said that a couple of times now, but what I also like to bring the personal side of like great people who sit on this chair. And what is it that you like to do when you're not doing research and publishing papers and and traveling around the world doing great research? Like, what are your hobbies?
It's a nice one to end with, bring it back to a little more of a human side. Oh, absolutely. Well, I've evolved in my passions. Also, I guess depending on the environment in which you are. I was born and raised on an island of Sardinia in Italy.
Oh, wow.
Which is a beautiful island, and certainly their water sports are a must. So I grew up actually playing water polo. Then moved to the US for my exchange year. They didn't have a water polo team, and so then I continued with swimming, which sounds similar, but is actually quite different of a sport. But I was in upstate New York in a town called Canandaigua, and there is a lot of snow. Certainly these days we're getting a lot of snow in Boston, so certainly very snowy. And I was fortunate that my host father, so you live with host family. So Ken, my host father, was, and he is a ski instructor.
Nice.
And so I was fortunate to spend half a year during the winter skiing and learning how to ski with him. So that has remained certainly as a hobby now that I continue to cultivate. And more recently now, I've also tried to think of, what's another sport that can be practiced throughout your life, and tennis came at the top of the list. And so I'm learning now how to play tennis, and I do still enjoy playing the bass guitar as a musical instrument. So all sort of different rock songs.
So really diverse interests. That's great. I'm so glad you're here that as well. Well, Enrico, thank you so much. It's been wonderful listening to your trajectory in your medical school and residency fellowship, research, global health, all the great work you've done in community service. True, congratulations on what you've achieved. I'm really looking forward to all the great things that you're going to do in your career. And it's great having you here in MetaCast.
Thank you, Randerson, for having me, and really thank you for what you're doing, for really putting together this wonderful production and platform through which we can talk about what wakes us up in the morning and gets us going, and we can hopefully share some stories to the next generation. So it's really admirable work you're doing.
Yeah, your story is certainly an inspiration. So everyone, this was Enrico Ferro, who has this incredible journey you just heard about. And I also want a final message to you. I want to remind you to subscribe to the channel. Make sure to check the other episodes of MetaCast. We have incredible guests here who share these inspirational stories. And as a final word, I also want to invite you to join us in the Meta-Analysis Academy. One thing I'll say at the end here is that today I'm also a part of clinical trials, a small portion, nothing like what Enrico does. But doing meta-analysis served as the gateway when I didn't have those opportunities. We were talking about doing the best with the resources you have. If you're not in Boston or in other major centers like this, it may be hard to do really great outcomes-based research or clinical trials. But it serves as a gateway for you to prove that you're able to, that you can do some statistics, that you can do some writing, that you know research methods. Then later on, things will evolve in your career and you have more and more opportunities. So I welcome you. I would invite you to join us in the Meta-Analysis Academy. Enrico, thank you again. It's been great having you on the show.
Thank you. Thank you, everyone.